Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of interviewing dear friend and colleague, Dr. Koji Matsuo, who is in the Division of Gynecologic Oncology in the Department of Obstetrics and Gynecology at the University of Southern California in Los Angeles, California. And the reason for this podcast is a discussion on the June lead article in our journal titled Modified Radical Hysterectomy for Stage IB1, less than 2 centimeters cervical cancer, assessment of temporal trends and oncologic outcomes in the United States. Koji, it's great to have you back on the podcast, and thank you so much for accepting our invitation.
Thank you so much. I'm pretty honored to be invited again. So this is my, I believe, the fourth podcast, but I'll be very humble. So I do my best to answer your questions. Thank you so much.
Of course. No, of course, it's always a fun and learning opportunity for me to discuss your studies. So we wanted to start by discussing what was the rationale for the study? Why did you consider that this was a relevant question to address at this time?
So surgery for cervical cancer continues to evolve over time. Breast radical surgery to offer curative intent surgical treatment with decreased surgical mobility and without compromising oncologic outcome has been the active area of research interest in your society in the past years. For T1B1 cervical cancer with tumor size of 2 centimeters smaller, radical hysterectomy has been historically the mainstay of surgical treatment. And per the Moro-Queru classification, radical hysterectomy is classified as type C1 hysterectomy to remove the cervix and block with surrounding tissues, including parametria, to the level of internal iliac artery laterally and deep uterine vein distally, upper 1/3 to 1/4 vagina, and at least 2 centimeter uterosacral ligament when performing nerve sparing. The rationale of this radical surgical procedure is due to the risk of tumor spread to the parametrial tissue, but radical hysterectomy is associated with significant intraoperative and postoperative morbidities such as pelvic hemorrhage, urinary tract injury, and postoperative neurologic bladder. The tumor size is an important risk factor for parametrial tumor spread. When quoting the recent large-scale JCOG-0806 study, quoting in reference number 5, the rate of parametrial tumor spread was 1.9% for clinical tumor size of 2 centimeters or smaller, and the risk jumped and increased to 12.9% for clinical tumor size larger than 2 centimeters. When certain risk factors are excluded, such as lymph node metastasis and deep cervical stromal invasion, the risk of parametrial tumor spread can be less than 1% for clinical tumor size of 2 centimeters or smaller. These favorable statistics justify to offer breast radical surgery for T1B1 cervical cancer, and the previous investigation has been mainly focusing on the role of simple hysterectomy. And recently, the oncologic safety and improved surgical mobilities of simple hysterectomy was confirmed for T1B1 cervical cancer, meeting the low-risk criteria in the SHAPE trial. Based on their result, together with CONSERVE trial result, the current NCCN clinical practice guidelines incorporate simple hysterectomy for low-risk T1B1 cervical cancer. Putting all together, breast radical surgery in early-stage cervical cancer becomes increasingly important, and this was the reason and motivation to conduct this study.
Excellent. So, Koji, if you can describe for our audience as well the definition of a modified radical hysterectomy.
Modified radical hysterectomy is classified as type B hysterectomy according to the Moro-Queru anatomy-based classification schema. This surgical procedure is defined as transection of uterine artery at the level of ureter and roofing the ureteral tunnel to transect the parametria at the level of ureter, taking 1 to 2 centimeter vaginal cuff margin as well as 1 to 2 centimeter uterosacral ligament. Per the current NCCN clinical practice guidelines, modified radical hysterectomy is indicated for T1A1 cervical cancer with LVSI and positive surgical margin in colonization. In a view of literature, role of modified radical hysterectomy for T1B1 cervical cancer has been examined in the clinical trial setting, but these studies generally combine the T1B1 and T1A2 together, making the interpretation of the findings specific to T1B1 cervical cancer challenging. Modified radical hysterectomy is another form of less radical surgery for cervical cancer, but utilization and outcomes in real-world practice has not been well described in the literature. We therefore decided to conduct this study to examine utilization characteristics outcomes associated with modified radical hysterectomy for T1B1 cervical cancer with tumor size of 2 centimeters or smaller.
So now let's get a little bit into questions about your methodology. What was the study population in this particular study? And also, can you tell us about, from a national cancer database, how can you tease out who had a radical versus a modified versus a simple hysterectomy?
For this retrospective cohort study, we queried the Commission on Cancer's National Cancer Database, or NCDB. NCDB is a venture collaboration mechanism between the American Cancer Society and the American College of Surgeons. This database is not a population-based design, but it captures nearly 70% of new cancer incident cases each year from 1,500 hospitals across the U.S. We decided to use this database because it allows us to evaluate the clinical tumor size that is likely the surrogacy of preoperative evaluation information. Because the hysterectomy modality is generally determined based on the clinical tumor size before surgery in preoperative evaluation, we consider this methodology as the key approach for this type surgical study. The study population included 2,902 patients with clinical T1B cervical cancer with tumor size of 2 centimeters or smaller, who had a primary hysterectomy from 2010 to 2020. Histology types were limited to squamous cell carcinoma, adenocarcinoma, and adenosquamous carcinoma. Clinical N1 and M1 were excluded, as these are likely representing metastatic disease seen in preoperative physical examination or systemic imaging. We assume that the patient with known N1 or M1 do not proceed primary hysterectomy per the current guidelines. The starting year of 2010 was chosen due to the availability of minimally invasive surgery, as this factor is prognostic based on the result of that trial. The hysterectomy modality was the exposure of this study. NCDB captures primary site surgical treatment, and they use the definition per the North American Association for Clinical Cancer Registry, or NACA. Of note, NACA is the organization established more than 40 years ago, and they sponsor several member organizations such as American Cancer Society, American College of Surgeons, National Cancer Institute, and Centers for Disease Control and Prevention. So NACA's coding schema is widely used in large-scale tumor registry in the U.S. We use the surgery coding schema for cervical cancer to assign the hysterectomy modality. The source link for this coding schema is shown in the reference 25 for your information. We assigned the codes 30 and 40 for simple hysterectomy. Code 51 was assigned as modified radical hysterectomy. Codes 50 and 52 were excluded as the hysterectomy modality was unclassified. Codes 53 and 54 were assigned as radical hysterectomy. Codes 60, 61, and 62 were excluded as describing as hysterectomy, not otherwise specified.
So now, Koji, let's actually get into the results. You gathered a study population of 2,902 patients. What are some of the things you found, and what would you like to highlight?
So before the result, I would like to quickly follow through the methodology that I lay over this investigation. The first, we looked the temporal trend of hysterectomy modality from 2010 to 2020, and the utilization rate was summarized in each year, and then used a linear segmented regression to identify a temporal trend. And then for the second step analysis, we assess the preoperative clinical characteristics associated with hysterectomy modality. We use the multinomial regression model, and all the measured presumably preoperative factors were entered in the modeling. This approach was based on the assumption that the hysterectomy modality is generally determined in the preoperative evaluation based on clinical factor. And then the third step was to assess surgical pathological factors obtained from the hysterectomy specimen as well as adjuvant therapy. And for the fourth step, we assess the overall survival associated with hysterectomy modality. The Kaplan-Meier method was used to generate the 5-year overall survival estimates. We created the Cox proportional hazard regression model, and the exposure outcome was adjusted for the previously selected clinical and pathological characteristics. Radical hysterectomy was set as reference group because this hysterectomy modality has been historically the standard treatment for stage T1B disease. The last step was to assess the exposure outcome for subgroup of analysis. We use the 8 subgroups of interest, including older age, younger age, squamous, non-squamous, presence or absence of LVSI, and then minimally invasive and open hysterectomy. In terms of the result, for the first, in terms of temporal trend analysis, we found that although remain less than 20%, the utilization of modified radical hysterectomy has gradually increased from 2013 to 2020, with annual percentage increase being approximately 4%. This was there was a counter decrease in the utilization of simple hysterectomy over time. For presumed preoperative clinical characteristics, we found that the modified radical hysterectomy was more likely to be performed in the Western U.S. region and at integrated network cancer program. In contrast, simple hysterectomy was more likely to be performed in community cancer program and with minimally invasive surgery. Simple hysterectomy was less likely to be performed for grade 3 lesions. For presumed postoperative characteristics, the rates of pathological lymph node metastasis were similar across the 3 hysterectomy groups, including 5% for radical hysterectomy, 4.4% for modified radical hysterectomy, and 4% for simple hysterectomy. Likewise, the rates of LVSI were similar across the 3 hysterectomy groups. We found that although lymph node metastasis and LVSI rates were similar across the 3 hysterectomy groups, patients who had a simple hysterectomy were more likely to receive adjuvant radiotherapy compared to those who had a modified radical hysterectomy or radical hysterectomy. Specifically, external beam radiation was given to 18% in the simple hysterectomy group and 13% in the modified radical and radical hysterectomy groups. We are not able to assess the exact indication for the adjuvant radiotherapy, but it may be possible that the simple hysterectomy may have a higher risk for positive or cross-surgical margin. And then as radiation menopause may result in cardiovascular morbidity and mortality, and radiation-related secondary primary ovarian cancer is associated with poor survival outcomes, it's possible long-term sequelae may need to be considered when offering simple hysterectomy. In terms of survival outcomes, the 5-year overall survival rates were favorable, exceeding 95% across the 3 hysterectomy groups, including 96.6% for radical hysterectomy, 96.3% for modified radical hysterectomy, and 95.8% for simple hysterectomy. After controlling for age, race and ethnicity, minimally invasive surgery, LVSI, and pathological lymph node metastasis and adjuvant radiotherapy, the adjusted hazard ratio for modified radical hysterectomy compared to radical hysterectomy was 1.23, with a 95 confidence interval being 0.73 to 2.06. Adjusted hazard ratio for simple hysterectomy and compared to radical hysterectomy was 1.02, with a 95% confidence interval being 0.7 to 1.48. And this survival association was consistent across the subgroup of interest, including age younger than 50, squamous histology, non-squamous histology, absence or presence of LVSI, and minimally invasive and open surgery. However, for the patient aged 50 or older, modified radical hysterectomy was statistically significantly associated with decreased overall survival compared to radical hysterectomy, but the difference in the 5-year overall survival rates was modest at 3.6% between 90.5% and 94.1%. And these are the key findings in this investigation.
Excellent. So, Koji, on some of the questions from our fellows, and this one from Christian Braun from Lucerne Hospital, he's asking, in the study, hysterectomy types were categorized based on procedure codes. How are these codes actually assigned in clinical practice in the U.S.? By the surgeon? Is it a clinical coder, or is it an administrative personnel? And what is the precise distinction between code 51 for modified radical and code 52 for an extended hysterectomy? Can you clarify that?
So the hospital's certified and trained tumor registrar captures the information for NCDB by using coding definition per the North American Association for Clinical Cancer Registry. We provided the coding list in the reference 25 for your information. We are not able to classify the reference referred code 52 either to modified radical hysterectomy or radical hysterectomy, and therefore the case with code 52 were excluded. There is a recent review article describing the overview of NCDB in the International Journal of Gynecologic Cancer published by Dr. Hicks Courant in 2024, as shown in reference 22. So this resource may be useful for future investigators who might be interested in this secondary database. So the NCDB's coding strategy used a hierarchy-based approach for primary site surgery. For instance, if the patient had a cervical biopsy first and the diagnosis of invasive cervical cancer is confirmed, then the patient underwent coronary colonization and confirmed low-risk cervical cancer. Then the patient eventually underwent simple hysterectomy. And altogether, this patient had 3 different time points interventions for the primary sites, but NCDB software and the registrar capture the most invasive anti-cancer treatment in this database, such as simple hysterectomy. So that's the mechanism of their data capturing schema.
Okay. Next question comes from Stephanie Gill in the University of Toronto. And she's asking, in the United States, does the code associated with a procedure relate to the payment received by the surgeon for that procedure? If it is, do you think this could have factored into why there were more radical hysterectomies compared to modified radical hysterectomies? Do you think that there are any other extrinsic factors that might have impacted the coding?
Apart from who capture this information for NCDB by certified and trained tumor registrar for NCDB using NACA's coding schema, actually, which information they will review, I couldn't find the granular in-depth information, but the possible reason why there's a kind of a skew the hysterectomy, the proportion would be the possible our inclusion-exclusion for hysterectomy codes. As mentioned earlier, we only used the 5 hysterectomy codes for the exposure assignment, and there were another 5 hysterectomy codes that we are not able to classify either to radical to modified radical to simple hysterectomy. So this skewed exclusion, this exclusion may be most likely have caused the selection bias and skew the distribution of hysterectomy modality in this study.
Excellent. So now let's move on to Matteo Marchetti from University of Padua. He's asking, the study shows a gradual increase in the use of modified radical hysterectomy over the last decade. What do you believe has driven this trend? And do you think it's more reflective of evolving evidence or changing surgical philosophy in early stage cervical cancer management?
Thank you. I think this is a very important question. The concept of radical hysterectomy has been repetitively discussed at the national and international meetings during a study period from 2010 to 2020. For example, the study period was from 2012 to 2019 for the SHAPE trial, from 2010 to 2019 for the CONSERVE trial, from 2012 to 2021 for GOG 278 trial, and from 2013 to 2017 for JCOG 1101 trial. Influenced by these ongoing prospective studies, surgeons may have started the surgical practice of less radical hysterectomy for T1B1 cervical cancer in the United States. This type of early or possible premature adoption of surgical practice prior to result of level 1 evidence occurred in minimally invasive radical hysterectomy for early-stage cervical cancer in the United States, and the utilization of minimally invasive radical hysterectomy started increasingly even before the first report of LAC trial at the 2018 Society of Gynecologic Oncology meeting. Being said, it will be important to assess if modified radical hysterectomy is safe for T1B1 cervical cancer in prospective setting.
So now let's go back to a question by Stephanie Gill, and she's asking about imaging. And she says, do you think the addition of imaging will greatly impact the procedure the surgeon will pick compared to what you have presented here?
So in 2018, the International Federation of Gynecologic Obstetrics, or FIGO, revised the staging schema of cervical cancer, and it incorporated the radiographic lymph node metastasis in their composite staging schema as stage 3CR. In the current study, we did not use the FIGO staging schema for the study selection. Instead, we used the American Joint Commission on Cancer TNM classification to identify T1B1 cervical cancer. This question of the impact of radiographic lymph node metastasis to guide the primary anti-cancer treatment, either to surgery or to definitive radiotherapy, is another important question and requires additional investigation.
Excellent. Now let's turn to Kara Fisher. She's at the University Hospital in Heidelberg, and she's asking, how do you interpret the results that modified radical hysterectomy in patients older than 50 years of age was associated with a decreased overall survival compared to the radical hysterectomy group?
I think careful interpretation is needed to assess the survival association for modified radical hysterectomy in patients aged 50 years or older. Although statistically significant, clinical significance was less robust, such that the 5-year overall survival rate difference was 3.6% between modified radical hysterectomy and radical hysterectomy. Lack of information on cause of death limits the granular interpretation whether this is due to cervical cancer death versus other cause death. One possible explanation may be that the cervical cancer in older patients has likely endocervical tumor growth as opposed to exophytic tumor growth in younger patients. The current study was not specifically designed to assess this subgroup of age 50 years or older. In general consensus, subgroup assessment is set as hypothesis-generating exploratory analysis. Therefore, additional investigation is necessary whether the observed exposure outcome association is validated and redemonstrated in other populations. In previous clinical trials, nearly 75% of patients in the SHAPE study were age 50 years or younger. The median age of the conserved trial was 38. Therefore, it may be indeed possible that there is a scarcity in data to examine breast radical surgery in older cervical patients.
So this question comes from Julia Gellison, University of Wisconsin in Madison, and she's asking, what do you think accounts for the high rates of simple hysterectomy in this cohort during this time period?
There are a few possible explanations for higher than expected rate of simple hysterectomy in the study population. First, exclusion of a number of cases with unknown hysterectomy modality may have resulted in the selection bias as mentioned earlier. Second, inability to identify low-risk cervical cancer due to lack of information on the depth of cervical stromal invasion and the conization surgical margin status in the study may have resulted in the inclusion of large number of low-risk cervical cancer where simple hysterectomy may have been already in practice in the U.S. during study period. Third, there was a significant practice variation for less radical hysterectomy based on hospital setting and region. Community-based hospitals had higher utilization rates of simple hysterectomy compared to academic center, so this NCDB data may have possibly provided the actual real-world practice of less radical surgery for T1B1 cervical cancer in the US.
Now, following on that, Matteo Marchetti at the University of Padua, he's asking, simple hysterectomy was performed in a considerable proportion of patients with stage 1B1 less than 2 centimeters or equal to 2 centimeters. Given that current guidelines limit its indication to very low-risk disease, how do you interpret its widespread use in this cohort? Are we underestimating its role or overusing it inappropriately?
In the study, nearly 40% of patients received simple hysterectomy based on our inclusion-exclusion. The interpretation of higher or lower than expected rate would be depending on how much proportion of the study population actually included the case meeting the low-risk criteria. If the prevalence rate of low-risk criteria is more than 40% of clinical T1B1 cervical cancer, such as 60%, then simple hysterectomy may be possibly underutilized. In return, if prevalence rate of low-risk cervical cancer is less than 40% of clinical T1B1 disease, such as 20%, then simple hysterectomy may be overutilized. So an important suggestion from the result of this retrospective study will be to assess what proportion of clinical T1B1 cervical cancer with tumor size of 2 centimeters smaller meets the low-risk criteria. Such information will identify and call for further investigation whether there is a role for less radical surgery in clinical T1B1 cervical cancer that does not meet the low-risk criteria.
This next question comes from Christian Braun, and he's asking, in light of the SHAPE trial, in which clinical scenarios does a modified radical hysterectomy currently have a role in our practice?
According to the current NCCN clinical practice guidelines, modified radical hysterectomy is indicated for T1A1 cervical cancer with LVSI and positive surgical margin in conization. According to the SCO and ASCCP evidence-based guidelines, modified radical hysterectomy is acceptable for adenocarcinoma in situ with positive surgical margin in conization. Based on the result of SHAPE and the CONSERVE trials, the NCCN clinical practice guidelines recommend a simple hysterectomy for T1B1 cervical cancer meeting the low-risk criteria. The guidelines remain recommending radical hysterectomy for T1B1 cervical cancer with tumor size of 2 centimeters smaller that does not meet the low-risk criteria. The result of this retrospective investigation proposed a possible role of modified radical hysterectomy in T1B1 cervical cancer that does not meet the low-risk criteria and warranting the additional investigation. Such investigation will limit the study population only to non-low-risk T1B1 cervical cancer by excluding low-risk T1B1 cervical cancer.
So now, Koji, I just want to ask a few additional questions. Want to be respectful of your time, but I'm going to challenge you here a little bit and ask whether you consider that modified radical hysterectomy has a role in patients with tumor size 2 to 4 centimeters. In this population, it's rare to see patients with parametrial involvement. One would say that the majority of these patients still don't have parametrial involvement. And when so, it is not the direct tumor extension, but rather lymph node disease. What are your thoughts?
Yes, actually, I found this question very challenging and difficult to answer. But before evaluating the hysterectomy modality for T1B2 cervical cancer with tumor size of 2 to 4 centimeters, I'd like to draw your attention and call for evaluation regarding the primary treatment approach for this disease group. We have recently presented an abstract at a research meeting in Berlin in October 2024. We performed a population-based assessment using a National Cancer Institute SEER database. The study population was T1B cervical cancer from 2004 to 2021. We looked at the temporal trend of primary hysterectomy versus primary definitive radiotherapy based on tumor size and the lymph node metastasis status. we found that there was a significant treatment shift from primary hysterectomy to primary radiotherapy for node-positive stage T1b2 cervical cancer with tumor size 2 to 4 centimeter from 15% in 2004 to 50% in 2021. Even in node-negative T1b disease, there was a treatment shift from primary hysterectomy to primary radiotherapy starting in mid-2010s. Despite this treatment shift from surgery to radiotherapy, overall survival was superior in the primary hysterectomy group compared to the primary radiotherapy group. This preliminary data is important in our society, calling for additional investigation. Regarding the role of modified radical hysterectomy for T1b2 cervical cancer with tumor size 2 to 4 centimeter, if quoting the JCOG-0806 study as citing in reference number 5, lymph node metastasis rates was 7.4% for clinical T1b1 cervical cancer and jump up to 22.2% for clinical T1b2 cervical cancer with tumor size greater than 2 centimeter. As mentioned earlier, the rate of perimetrial tumor spread was 12.9% for clinical T1b2 cervical cancer. So in this group, it may be possible that the patient will receive adjuvant radiotherapy more for pelvic lymph node metastasis reason over perimetrial tumor spread. The historical Landoni study, radiotherapy after radical hysterectomy is associated with increased risk of morbidity. When comparing perioperative morbidity for modified radical hysterectomy in JCOG-0806 study to historical JSOG data, citing the reference number 4, the complication rates appear to lower for modified radical hysterectomy compared to radical hysterectomy. So this may be the area to offer less radical surgery as you speculated.
So now, Koji, just two questions. What do you see as the weaknesses of your study?
We noted that the lack of information for depth of cervical stromal invasion and the consolidation surgical margin in order to identify low-risk cervical cancer is a major drawback in the study. Mixing low-risk and non-low-risk cervical cancer in the study population limits the interpretation and the clinical implication. Other limitations, including lack of information for cause of death to assess cervical cancer mortality, intraoperative and then postoperative mobility, quality of life metrics, and recurrence data were not available in NCDB, but these are important outcome measures in this type of investigation.
And Koji, as the last question, I typically tend to ask, how should we incorporate this data currently today in our patient care?
Because the study was described rather descriptive retrospective evaluation, the result of this investigation alone would not change the current clinical practice. Rather, the result of such retrospective study are best interpreted or best fit as hypothesis-generating data to call for additional investigation. First, prevalence rate of low-risk disease in T1b1 cervical cancer with tumor size of 2 centimeters less will need to be assessed. Second, survival assessment to compare modified radical hysterectomy to radical hysterectomy for T1b1 cervical cancer that does not meet the low-risk criteria would be needed. If such assessment shows comparable oncologic outcome, then prospective non-inferiority study for survival assessment would be ideal. Recent JCOG-1101 study examined the role of modified radical hysterectomy for stage T1b1 cervical cancer with tumor size of 2 centimeters smaller, but they did not exclude the low-risk group, and they did not have a control group with radical hysterectomy, making interpretation difficult. Given decreasing incidence of cervical cancer in the United States, society-based multi-center approach would be recommended.
Excellent. So, Koji, thank you so much again for this discussion. Thank you for accepting our invitation. Congratulations to you and the entire rest of the team who put together this study. Really very, very exciting information. And again, we look forward to our journal club on this same article. And I want to thank you once again for all of the contributions you have made to gynecologic oncology.
Thank you so much. I hope I answered to these important questions adequately. Thank you so much.